right, so we're going to switch gears to our third speaker, Dr. Amy Thorsen, who trained at Beth Israel Deaconess for surgery and then did her colorectal training here. She currently is the director of the Pelvic Floor Clinic, practices at Abbott, and is on faculty with the University of Minnesota. And her talk today is sacral nerve stimulation, what to do when it doesn't work.
Thank you. So I don't have a disclosure slide, but I do have a relevant disclosure that's in the handout that you got today, that I do educational programs for Medtronic, and Medtronic makes the main sacral nerve stimulator device that we use presently. So sacral neuromodulation is really a technique that we use to stimulate the sacral nerves to modulate reflexes that involve the colon, the rectum, and the pelvic floor. And really what we do is use mild impulses to improve or restore anal continence. And so we don't really have a great understanding of how the therapy works. We know that it's a sensory mechanism, however. And those sensory afferent pathways may control some muscular function. They may help with misplaced sensory signals. They may help the patient get increased sensory input. There's been a little data that there's been some changes in colonic motility. It may change rectal capacity, and it helps dysfunctional neural reflexes. So the data on sacral neuromodulation therapy is fairly good. There's a lot of studies. This is a meta-analysis of 34 studies looking at 665 patients. And then you can measure it a lot of different ways, but these studies overall showed that there's improvement in the number of incontinent episodes. You have improvement in multiple different incontinence scores, such as the Cleveland Clinic score. It helps with urgency, which some of our other treatments don't always affect, and help with the ability to defer defecation. And then there are also studies that show that it helps improve quality of life. And that there may be some issues with helping also mean resting pressures, even though this is a sensory phenomenon. It's fairly low morbidity, and the rate of explantation is fairly low, which makes it a very safe option to treat our patients with. On this slide, you can see that we're looking at some of the data points. And so if you look at the goal of being better than 50% improvement in the number of accidents, long-term data suggest about an 84%. The possibility of 100% continence, so curing the incontinence, is up to a third of patients may experience this. If you, however, look at this at a more honest approach, looking at intention to treat, this data is more at the 54% for 50% or more improvement, and about the 20% level for intention to treat, meaning all comers who tried the therapy. So based on this, sacral neuromodulation therapy is one of the high evidence treatments recommended for treating fecal incontinence, along with sphincteroplasty for the ASCARS guidelines, and similarly with the American College of Gastroenterology. So I just said that, it's about 54% intention to treat. So what should we do with SNS doesn't work? So when I have a patient that comes to me with this, there's sort of different pathways that we may go down. For some of the patients, some of my patients who it worked for a while and then all of a sudden it's not working anymore. I have patients who've come to me that had it placed elsewhere. So I have sort of an algorithm for that. And then there are patients who I tried, it failed, it never really worked. And so those patients may really need another option. So this is our troubleshooting algorithm for patients. You'd be surprised at how many patients will come in saying their SNS doesn't work and the device isn't even on. So you really have to interrogate it and make sure that it's worked. So if everything's good, then there are 7 different programs and a lot of different settings, and so you really need to look at that, and then you can get success or failure. So at this point, if all of this doesn't work, we have sort of 2 parallel pathways for a lot of patients who, if they haven't been studied recently. So one is that I may take an x-ray to see, did their lead move? Was it placed elsewhere? Is it not in the right position? For patients that something's fractured, replaced. I had this one patient who played around with the battery, twisted it, and broke off the lead. So I've had to replace that and tell her don't touch down there. And then if the lead looks good, we'll try to reprogram, and then we'll go down my other algorithm. So the other algorithm is getting dynamic imaging on these patients. This is, Sarah showed you these beautiful MR defecographies. This is a really old-fashioned fluorodefecography where there's vaginal contrast. You can see some small bowel loops. This is the peritoneum coming down. And you see this rectal intussusception. And so you've heard a lot about rectal intussusception in the last 2 talks. And so I'm going to talk about it just a little bit more. So it's thought that high-grade internal rectal prolapse it contributes to fecal incontinence. Only 20% of patients that have this will present with isolated fecal incontinence. The majority of these patients will have incomplete emptying, obstructed defecation symptoms, and fecal incontinence. And so it's thought that high-grade intraanal prolapse will cause FI by causing lower resting pressures. You might get your rare reflex, which is a reflex that tells our internal sphincter muscle to reflex when the lower rectum's filled. It may keep firing, so people don't have that internal sphincter muscle close appropriately. And then what's the easiest for us to understand and what we see all the time is that these patients can't evacuate completely. They have low resting pressures, so they try to get everything out. They don't get everything out. They start walking around, and then they leak. So it's a very common mechanism that we see. Again, we use, when we read our defecographies, the Oxford grade rectal prolapse grade. And so we're looking at people who are grade 3 and 4, meaning in the upper anal canal and within the anal canal that we're considering ventral rectopexies for. So we started being more aggressive with treating rectal intussusception patients with this paper that came out from Oxford. This is looking at their patients who had sacral nerve stimulation for fecal incontinence. And then what they did is they went back and they looked at their testing and looked at their defecographies, and they found that about a third of their patients had high-grade internal rectal prolapse. So these patients would still pass a peripheral nerve evaluation, the test phase, to get implanted at a lower rate, but definitely enough would pass. But if you go on to implantation and you look at their pre-op continence score versus their post-op, there really isn't a change in the patients who have the high-grade internal anal prolapse. And if you measure your rate of success by improving your incontinence score by half, very few patients will make that data point with the high-grade internal prolapse. They also found that the high-grade patients really had no improvement in quality of life, and so the conclusion was that internal prolapse that's high-grade may affect the success of sacral neuromodulation therapy. And so you saw in Ann's talk the success rates of treating this surgically with ventral rectopexy. Besides this one outlier study that showed only a 20% success in operating on internal prolapse, improving fecal incontinence, most studies, and what I quote patients, is usually about a 50 to 90%. Again, it may be really based on what kind of incontinence. The patients who have urgency, I'm a little bit more iffy if ventral rectopexy is the right thing for them, although it does help some of these patients. The patients who, again, are seeping, have post-evacuation, have a lot of evacuation issues, these are the patients that do quite well in terms of treating their internal prolapse. So based on this data, we have this pathway that, for us, we actually do a lot of dynamic imaging in our fecal incontinence algorithm before implanting. So that's why we actually believe a lot in pelvic floor testing, trying to figure out who's a candidate for ventral rectopexy, who's a candidate for sacral neuromodulation therapy. But patients get treated elsewhere. People have different algorithms. So this study is looking at the patients who you do the ventral rectopexy on first, who aren't perfect, and most of those patients will respond to sacral neuromodulation therapy after. So if I have a young patient that has a high-grade intraanal prolapse, most of their incontinence is urgency, those are the people who I counsel very extensively that you may get 2 procedures out of this. We're going to fix your internal prolapse, see what we get, wait 6 months because it might take your sphincter 6 months to recover, and then if you're still having an issue, we go on to sacral neuromodulation therapy. So what about ventral rectopexy after sacral neuromodulation therapy? There really isn't any data published out there. I've probably done about 10 to 12 patients in the situation. Some have been my own who have deteriorated. Some have been people who've had an interstim placed elsewhere. And I can tell you that it's helped a lot of these patients. I have several patients who don't even have their interstim on anymore because really their problem was their obstructed defecation and incontinence. So that was the good news of trying to make it work. So the question is what do we have left if it doesn't work? Because it doesn't work all the time. So we've heard a bit about injectables and CEQA. There's some things on the shelf that we had in the past, bowel sphincters and a mesh sling. And then the future hope maybe is stem cells. And I'm going to go over some of these briefly. And we're trying to avoid a colostomy is what we're really trying to do. So injectables, the idea behind this is to bulk tissue around the anal canal and approximate the anal mucosa. The theory behind this is that it helps close the anal canal and it helps increase pressure to prevent accidental bowel leakage. There's a lot of studies, and this is just showing that there's a lot of different materials injected in a lot of different places by a lot of different methods and techniques. So only one of these has come to the United States so far. This slide is just showing you this is an intersphincteric injectable that never made it to the United States. You can have submucosal injections, which is how Celesta is done, intersphincteric, perianal, anal mucosa, and then you can do it by exam or by ultrasound guidance. So this is the medication that's used in the material marketed as Celesta. It's a microsphere that's created to have a particle size that's not supposed to allow any kind of migration, and it's had documented stability in other medical uses. It's made in a viscous material, so you can inject it well. And then the idea is that it creates a little environment that you can have fibroblast and collagen and bulk up the anal canal. This is really simple to do. I've done a lot of these. You use an enema prep. You give antibiotics before. I did it in the left lateral position. You inject in 4 sites. You leave the needle in for a little at a time because you want the material to solidify and not just ooze out when you pull your needle out. And then we just kept the patients on some stool softeners before their first bowel movement. And then the majority of patients will come for a second treatment in 3 months because they won't be optimized. So this is the study that got the Celesta approved here in the United States. There was a sham group versus the treatment group. And really what you could see is that about half the patients improved with the Celesta, a third of the sham patients actually had improvement in terms of if your measurement is 50% or more improvement in the number of accidents. But this didn't seem to translate to any change in their incontinence scores. And it really had really minimal change on their quality of life. Long-term results did show, and this is only up to 3 years, that if it worked for you, at the first 6 months, it's going to work for you at the 3-year point. And then a very small percentage of patients had complete continence with that. So going back to that, there really hasn't been any new data out on this. We did a lot of this when it came out just because of the ease of delivery. Since then, I think I've personally been, and many people have been disappointed with the actual clinical results we see in our patients. It's still available. It's hard to get insurance to pay for it, has been my experience recently. And so we haven't been doing a lot of this recently, but it's out there. So CEQA is something that our institution isn't personally involved in, but it is done in several centers in the United States. The idea is that the radiofrequency energy to the anal canal will cause tightening and collagen deposition and scarring. And the original pilot study that got this approved was an 80% response rate in terms of improving incontinence scores by 50%. A more recent study looked at 40 patients that were either treated or had a sham treatment. And so these patients had a VISE score, which is a European incontinence score initially of 16.8%. And then after treatment, the treatment group went to 13.2, the sham group went to 15.6 at 6 months. But basically, this really had no impact on quality of life or pad usage and whatnot. So to me, it seems like it's not the most promising option, but it is available. The magnetic sphincter. So we, in the past, had the artificial bowel sphincter that was taken off the market. Then we were getting excited because the magnetic sphincter came out, and it was approved by humanitarian device exemption in January 2016. This is an alternative FDA process in order to treat a disease that affects less than 4,000 people a year. So it's a special tract for not widespread use. And it was thought that this didn't expose patients to significant risk or injury. And so you had to implant these, you had to have an IRB approval at your institution. So this is a single center study with the data showing that out of patients implanted at this center, European center, that 3/4 of them had at least a 50% improvement in their incontinence scores, and that they had improvement in quality of life in all domains. So the next study is a multi-center study, and there were 4 centers in the United States, 4 European centers. We were one of the United States centers, looking at 35 patients, most female. The median follow-up is 5 years, and what you can see is that the success results are in the 50 to 60% range. This is the explanted, so there were a fair number of patients who were explanted, 7 overall, and 8 patients who required reoperation. So some success, but maybe a little bit more morbidity compared to InterStim. So if you did get a successful device implant, you had significant improvement in frequency of accidents. This also helped with your incontinence score and improvement in quality of life. So it did help on multiple measurements of looking at improvement. So what happened with this is that there were 2 ongoing trials in Europe that were actually randomizing the magnetic sphincter to sacral neuromodulation therapy. I think those studies actually were completed. They've not been published because the device was acquired and it's been taken off the market, not because of safety issues, but because of a lack of interest in providing the device and support. So we've put in about 12 of these at our center since we had it, and now it's gone. So we're hoping maybe it'll come back. Similarly, there was a trial for the Posterior Sling. This is another minimally invasive device, very similar to the urinary slings. You would put the sling around a transobturated route. The idea is that you're functionally lengthening the anal canal. There was actually a controlled study that showed about a 69% success rate. This actually got FDA approved, but never made it to market because it was all around the same time as all of the mesh lawsuits. So that's not available either. So last, stem cells. This is not really ready for prime time yet. There's 29 animal studies. There's a lot of different models in these studies of like how do you create the incontinence in the animal, what animal do you use, what kind of stem cell do you use? Do you use adipose? Do you use muscle progenitors? But all of these studies do show that this seems to be a safe technique to consider. There's presently 7 human publications. The first is actually a fistula procedure that showed some improvement in continence. These are mostly observational case reports, not a lot of data, but there is some suggestion that there might be some improvement in quality scores and some in quality of life scores and in incontinence. So something that might be out there on the horizon. So to conclude, when sacral neuromodulation doesn't work, honestly, my goal is to try to make it work somehow. I repair any rectoanal prolapse, and if it's reasonable, I'll revise the lead when it's appropriate. You can try bulking the sphincter with CEQA or with Celesta, but it's probably not going to do anything. You can pray that maybe the magnetic sphincter will come back, but I'm not so sure about that. And then really, we're just going to wait for the future to see what's next. Thanks.